Hi, welcome to Learning from Caregivers, an interview series where we'll be digging into the latest information from both on the ground caregivers and caregiving scientists to help people support the needs of older adults, their families, and communities. This is a podcast for health professionals and for really all of us who care for older adults. My name is Joan Monin, and I'm an associate professor at Yale School of Public Health, and I'm so happy to have with me today Dr. Catherine Riffin, an assistant professor of psychology and medicine at Weill Cornell Medical College. I had the pleasure of getting to know Catherine pretty well when she was a postdoctoral fellow in geriatrics at Yale from 2015 to 2017. And she's now really leading the way in helping care professionals for older adults provide family-centered care. So, healthcare systems, and for example, she's really looking at how clinicians can identify, communicate with, and assist caregivers in clinical encounters. So today she's going to be talking about that with us. And welcome, Catherine. It's so great to be able to catch up with you.
Oh, it's such a pleasure and an honor to be here, Joan. Thank you so much for this invitation.
Yeah, so you've been studying a lot of things about caregiving and emotions and health and relationships like over your whole career. But how did you get interested in researching specifically the ways that clinicians work with older adults in a way that's more family centered?
So I really got interested in this topic for a whole variety of reasons. As you know, I'm just really interested in social relationships more broadly and just understanding how people bring their own values and perspectives into their interpersonal interactions and conversations. And this is really important, especially in later life where families often need to work together to make decisions, and especially around health conditions when maybe one or more of the family members has an ongoing either chronic or acute illness that needs specific management. But really from a personal perspective, I had been very actively involved in healthcare discussions with my mom, who was caring for my dad, she was serving in a dual caregiver role. She was caring for my dad, who's actually passed away now about 7 years ago, but he was battling cancer. And at the same time, she was caregiving for her mom, who was my grandmother. And we used to sit in on these family discussions. And it became so clear to me that that managing chronic illness and disease in later life is truly a family affair, and that people can just depend so much on their spouse, but also on their adult children to manage health conditions. And people really don't operate in silos. If you're making advanced care planning decisions, or if you're even just making more of the routine medical decisions around medication management, or whether to do physical therapy or some other type of therapy, it can be really important to work with the family. So that's why I think, that's how I got interested, and why I think it's important for clinicians, because, you often see families in later life.
Yeah, I mean, from the family side, it seems like a really clear need, but it seems like on the clinician side, they're not quite sure how to do it right because the system is not set up like that. So one of the questions I had for you is, the first step is probably to identify who they're going to be targeting as the caregiver or as the family. Can you tell me more about your work on that and why it's important?
Yeah, so identifying the caregiver is really the first thing that you need to do in a whole stream of other activities. So you have to know who the caregiver is so that we can ask what they need to care for both the patient and for themselves. It's sort of the first step in being able to evaluate their own needs and risks, which then can be addressed through the provision of more tailored resources, training, and other supports. But you have to do this by first knowing who the main caregiver or caregivers are. And so I say caregivers because a lot of times in families, there are lots of quote caregivers. Caregivers don't often identify as such. I'm just his wife. I'm just not just, but I'm a spouse. I'm a daughter. I'm a son. I'm a friend. And so in this context, there may be one spouse who's taking his or her partner physically to the medical appointments, but then an adult daughter might be managing the medications at home, or another adult child might be just calling in to give emotional support. So it's important for the clinician to be able to identify who are the various people that are involved in this patient's healthcare. So it can help them to coordinate among all of the different parties, and that, okay, if the wife is sitting in the doctor's visit with me as the clinician, that person may not actually be the one who's managing the medications at home. They might just be here at the visit and taking notes. So maybe there are better ways to correspond with the person who's actually engaged in that task. So, which is the next step.
Yeah, it's almost like you need to have some kind of measure that has the different roles assessed for the clinician, like who's the one who does this, who's the one that does the medications. Are there people that need to be included in the conversation but aren't the main people that are going to be taking action? I mean, it seems like a lot of work on the clinician side to do that, and there's different support people in healthcare offices, like social workers and things like that. Can you say a little more about those people's roles and how they might kind of facilitate this for whoever the primary clinician is?
So you're getting at something that's like really important, and that is our medical system here in the United States just is not set up well to support clinicians in providing family-centered care. Their visit times are too short. Their electronic health record only allows them to correspond with a patient. Some of the HIPAA laws kind of preclude some interactions. But also there's not as great an integration between behavioral health, like mental health care, and medical care. And so this can be really challenging. So practices that might be available to people in like high socioeconomic status, or who are going to like academic medical centers, they may have access to a social worker or to a psychiatrist or a psychologist who's very well embedded within the context of the primary care practice. And I'm talking about primary care because that's where my bread and butter is. It's where my heart and soul is, but it's also true, even in the palliative care setting. I have a really good colleague who I'll give a shout out to right now. His name is Dan Shalev, who's doing excellent work in this space. He's a psychiatrist and a palliative care doctor. And his work is really emphasizing the integration of behavioral or mental health care within the palliative care setting, because that's really important too, and it doesn't often get integrated. So some of my work has shown in the primary care space that there is not this good linkage, and his work shows the same thing in palliative care, where it's even more important to address the family system, emotional needs, in addition to some serious chronic illness issues.
So would you have any recommendations for primary care for how to assess who the caregiver is?
So I have two things that actually we're working on right now. One is, so this isn't necessarily I guess the major recommendation for clinicians would be just to even ask the question, what do you need to help care for yourself? And what do you need to help care for the patient? Because we know from other national surveys that these questions just aren't really asked, and that the caregiver is often kind of assumed to be part of the visit, but isn't explicitly asked. So that's a very simple strategy that you can do without all of the fancy research, without any fancy tools, just taking the time to do it in the office visit. Just asking, how are you doing with all of this? How do you feel? And do you feel like, when you're leaving the visit, do you know how to manage the medications? There are public policies now. One is called the CARE Act, which was signed into law. It was model legislation by AARP, and essentially it mandates all hospitals across the United States to identify the caregiver and provide them with appropriate training and support. And this doesn't often happen. Like even though it's legislation and it's been signed into law in like 43 states across the US, it doesn't always happen. So that's something that you can do even without fancy tools. Just say, upon discharge in the hospital, do you feel like you understand the treatment plan? And it does happen. Some clinicians I'm sure are listening to this and saying and nodding their heads and drinking the Kool-Aid and saying, we do this all the time. And so kudos to you. We're so proud and impressed, but we do know from kind of looking more broadly across the United States that it doesn't always happen. And there are huge challenges with this, which I'm happy to talk about or save it for a later point in the conversation, but there's not enough time during many visits. So, I'm giving you this recommendation to ask this question, but a major challenge is time. The more complex the patient, the longer the appointment, and the greater likelihood that there will be a caregiver involved. So it's hard enough for doctors even just to get to all of the patient's needs if they have multiple chronic conditions, let alone the caregivers. And so you might feel like asking that question is opening up a can of worms. But what I would say sort of as a rebuttal to that is that I'm sure that many health professionals who are listening to this podcast have had the experience of a corridor conversation. The patient's sort of, leaving the room and going out to the waiting room, and the caregiver will pull you aside and say, and, I'm really concerned about their driving, or I'm really concerned about this medication, or I'm so stressed, I don't know what to do, and, having a breakdown. And you don't want that to happen in the corridor. You want that to happen, as part of the visit, as part of a discussion that can actually lead to actionable, meaningful change, not when you're rushing out the door trying to get to the next patient. But time is a huge problem. And again, it comes down to the health system is not necessarily set up to support you in having these longer visit times.